which is near Washington, D.C., the capital of the United States. And I am very happy to be here with you this morning. And I love seeing everyone talking together, because that's what this conference is all about. It's sharing experiences and sharing questions, and hopefully I can give answers to the questions that you have about oral atresia. Before we start though, I want to say a huge thank you to Hong Yan. There we go. He's doesn't like to have his picture taken, but you can see him in the back with me and a patient. He also takes care of my family. We came a year and a half ago, and this is my family at the Great Wall with my wife, Sonia, and Ethan, my son, who is 17, and my daughter, Emma, who is 13. So, Hong Yan, thank you very much for all that you do. The animations aren't playing, but that's okay. We have really 3 things that I hope that you will understand at the end of the conference. The anatomy of the ear and oral atresia and hearing loss, to know the options, the choices that you have for helping your child hear, and to appreciate the evaluation and the operation and the results of ear canal surgery. So first, we have to talk about the anatomy of the ear and how the ear works. So sound comes into the ear canal and vibrates the eardrum, or the tympanic membrane, which vibrates 3 ear bones: the hammer, the anvil, and the stirrup. The ear bones carry the vibrations to the cochlea, and inside the cochlea, very special cells convert the mechanical energy of sound to an electrical signal. And that electrical signal travels down the hearing nerve and goes to the brain. We talk about 2 different kinds or categories of hearing loss. The first kind is sensory neural hearing loss. That is a problem in the cochlea and the auditory nerve. As we get older, many of us will develop nerve-type hearing loss, but that is not the type of hearing loss that children with oral atresia have. The type of hearing loss that they have is what we call a conductive hearing loss. It's a problem with the transmission or the conduction of sound to the inner ear. The inner ear is healthy. The cochlea is fine, but without an ear canal and without an eardrum, and with the 3 ear bones that are not vibrating, these children have a conductive hearing loss, a problem with the sound conduction to the inner ear. So first, let's talk about microtia. Microtia in English simply means small ear. Micro is small, the OT is ear, so microtia is small ear, and it really refers to just the auricle, or what we call the pinna. There's variable development in the auricle, but it's almost always accompanied by some underdevelopment or oral atresia of the ear canal and the middle ear bones. A plastic surgeon years ago developed a classification for microtia. So grade 1 is just a small ear, but it has all the cartilage that we see in a developed ear. Grade 2 is just a little bit smaller without the cartilage, without some of the intricate framework of the cartilage. Grade 3 is the most common. That is the small ear, sometimes with cartilage, sometimes without cartilage. And then very rare, there's anotia, where there is no ear development at all. So there are options for rebuilding the outer ear, and I am not a plastic surgeon, so I will only mention these options. Number 1 is observation. Number 2 is a prosthetic ear. So this is an ear that's sculpted out of silastic or silicone that's painted to the child's skin color, and it's placed on either with medical tape or with implants. There is rib cartilage. Rib cartilage takes a piece of the rib and carves it or sculpts it into the auricle, and then in 3 operations, there is the framework placed, and then the lobule is created, or the earlobe, and then the ear is brought out. That's using the child's own rib cartilage. And then finally, there's the polyethylene implant called Medpor or Supor that you may also be familiar with. And so that is really all I'll say about microtia, because I don't do microtia repair, but I work very closely with plastic surgeons and facial plastic surgeons to coordinate the canal surgery with the microtia repair. All right, so what is congenital oral atresia? This is absence of the ear canal. There's really no eardrum, with variable development of the middle ear structures. We talked about those 3 ear bones. Almost always, the first 2 ear bones, the hammer and the anvil, are fused together as one ear bone. There's often good development of the 3rd ear bone, the stapes bone, but there's wide variability in the development of those ear bones. It occurs about 1 in 10 to 20,000 births. The vast majority are in one ear, or what we call unilateral. For reasons that we don't know, boys are more commonly affected than girls. And again, for reasons that we don't know, the right ear is more commonly affected than the left ear. How did it happen? We don't really know. There are theories about both genetics as well as inside the womb in the development of the ear, but we really don't know how this occurs. What we do know is that the cochlea, the inner ear, develops from a completely separate system inside the developing fetus than the middle ear or the ear canal. So the cochlea develops from the otocyst, which is part of the neural system, the nervous system of the embryo or of the fetus, and then the middle ear and the ear canal develop from a separate system. And what that means is that most children with oral atresia have normal inner ear function. So if you can get sound conducted to the cochlea, they hear normally, they hear well. The question is, what is the most effective way to deliver sound to the inner ear? When I see a child with oral atresia, I really talk about 2 things: the birth history, how was the pregnancy, how was the delivery, did the child require a stay in the newborn intensive care unit, and I also want to know about the family history. Is there a history in the family of microtia and atresia? I look at the physical exam and look for associated features that may suggest a syndrome, and there are syndromes associated with microtia atresia. Those syndromes include Goldenhar or hemifacial microsomia, where you see in this child the mandible or the jawbone didn't develop quite as well on the right side as it did on the left. There's a condition called Treacher-Collins, where there's underdevelopment of the outer part of the skull, which also includes oral atresia, and a condition called branchio-otorenal syndrome, where children have underdevelopment of the ear with a little cyst or sometimes a pit in the neck, as well as problems with kidney function. So I have to be on my toes to look for these findings. After the physical exam, the hearing test is very important, and we do hearing tests in infants. The hearing test measures the electrical activity in the cochlea and the auditory nerve when you put sound through a bone conductor. So when you deliver sound to the ear, the cochlea, the inner ear, converts that sound to an electrical signal, and we can measure that electrical signal in the brain. And that's how we do hearing testing on infants and children who can't participate in a behavioral audiogram. Now, as children get older, they can participate. When you hear the tone, put the block in the bucket. Or when you hear the tone, raise your hand. A behavioral audiogram is really what we want to know. How well is the child hearing and understanding? So when do I recommend imaging? And the imaging study is a CAT scan or a CT scan. An infant or a toddler does not need a CT scan. I only recommend the CT scan if we are considering doing ear canal surgery. And if ear canal surgery is not a consideration, then the child doesn't need a CT scan and have the exposure to the radiation. I don't do canal surgery until the children are at least 6 years old. So there's no reason to get a CT scan until the child is that age. And I think that's an important point. So the imaging study I don't recommend until the child is maybe 5, when we're starting to consider whether to do ear canal surgery. And so what is the next step? If oral atresia is in one ear or unilateral, there are options. Observation with monitoring the hearing. We know that children with normal hearing in one ear will develop speech and language on a normal path. The problems that children have would be hearing in background noise, parties and restaurants. When there's a lot of noise, it's harder for children with hearing loss in one ear and normal hearing in the other to hear and understand. The second issue is sound localization. Where is that sound coming from? When you have good hearing in one ear and not as good hearing in the other, it is more difficult to be able to tell where is the sound coming from. But observation is absolutely an option in children with oral atresia in one ear. A bone conducting hearing device is an option. So this is a device, as many of you know, that takes sound energy, and through this oscillator, it vibrates the bone of the skull. And that vibrational energy is sent directly to the cochlea. The bone conducting hearing device, however, many children don't like when there's a party or background noise. It amplifies background noise also, and some children don't like the bone conductor. It also does not allow us or allow children to locate sound in space. So we locate sound in space through time difference between the two ears. So if there's a sound off to my right, that sound hits my right ear milliseconds before it hits my left ear. And the brain processes that time difference. When you wear a bone conducting hearing device, the sound energy comes into the device and it vibrates the bone and stimulates both cochlea at the same time. So children can't rely on timing difference to figure out where's the sound coming from when they wear a bone conductor. And then the third option would be to consider the ear canal surgery if the child is 6 or older and the anatomy is good. We'll talk about that in just a bit. So here's a child who wears a bone conductor with a normal hearing ear on the right side, but I think there are limitations. And when I see children and parents come in and say, my child won't wear the bone conductor, I say, it's okay. We have enough battles to fight as parents, and having your child wear a bone conductor when they have normal hearing in one ear, we don't know the long-term benefits. And I say that is not a battle that you have to face. It's something that if the child will wear it, great. If the child doesn't want to wear it or takes it off, that's okay too. But we want to set the child up for success in the classroom. So suppose the oral atresia is in both ears, it's in bilateral. Here, I don't recommend observation with monitoring. I think the bone conductor is critical. I think the bone conductor is necessary for good speech and language development. And then if the child is older, as the child is older, we can consider canalplasty if the inner ear function is good and if the CT scan shows good anatomy. But I definitely recommend the bone conductor in children with ear atresia in both ears. Okay. So what are the options for hearing improvement? This is objective number 2. What are the choices? So there are many choices, including just one sec. Not sure why that quit. Oh, that did it. Just fast forward to. Okay, sorry about that. Well, I like to walk around and be out in front, and then I think I'm hitting the cord by accident, so that may be the issue. Okay. Okay, there we go. So, options for hearing improvement. We talked about observation with just monitoring the hearing if the child has oral atresia in one ear. A note for school, sitting in the front of the class, setting the child up for success in the classroom, making sure the child can hear the teacher and sits near the front. In the United States, we have an individual education program so the child's family can register with the school to make sure that that child is set up for success with resources, preferential seating in class, so that the child succeeds well in school. An FM system is where the teacher wears a microphone and the child wears a hearing aid or an earbud, and the teacher's voice goes directly to the child so that the child can hear the teacher well. A conventional hearing aid, if there's enough development of the auricle. Bone conducting technology, this is called the Adhere. It's made by Med-El. It's an adhesive that goes behind the ear, and you take the processor and you simply snap it onto the adhesive. Bone anchored hearing device is a surgical procedure to place an integrated or a bone integrated conductor, and then the canal surgery. So the bone conducting hearing device, it's non-invasive, worn on a headband, and it is effective. It can be uncomfortable for the child. There is some sound loss or sound attenuation because the sound has to travel across the skin, across the tissue underneath the skin to the bone. But it actually is very effective, and it will support speech and language development in children, especially with oral atresia in both ears. And then, as I mentioned, I strongly recommend a bone conductor in children with oral atresia in both ears. So we'll just run through some of the osseo-integrated or the surgically implantable bone conduction devices. There's the Ponto device by Otakon Medical. So this is a device this is the implant that's surgically placed into the bone, and then attached to the implant is a post. The post comes through the skin, and when the child wears the processor simply snaps onto the post. So you can see it better here. This is a device by a different company called Cochlear. So the post sits behind the ear, and then you simply snap on the processor to the post. There's better conduction of sound with these devices because there's a direct coupling of sound energy to the bone through that post. It does require surgery, and for some patients, some children, they get a lot of inflammation or infection around the post. And if that happens, sometimes we change out the post to a magnet. And so the Cochlear Corporation has come out with a magnet now that sits beneath the skin. So here's the implant that's placed into the bone, and instead of the post attached to the implant, now this magnet is attached to the implant, and the magnet goes completely under the skin. The child still has to wear the processor on the outside, but the processor connects to the post or connects to the implant through the magnet. There are no wound issues, obviously, so in children who have had a lot of inflammation or infection around the post, we'll switch them to a magnet. It does require surgery, of course. It's a bit larger, if an active child is out on the playground, can the processor fall off the magnet? I haven't heard too many complaints from parents about that, but theoretically it could fall off. And because again, the sound has to go through the skin or across the skin, the sound conduction is not quite as good. However, these newer magnets conduct sound very, very well. The second is also made by Oticon, and it's called the Sentio device. It's much smaller than the cochlear device. We make a little impression in the bone, and we fit this part into that little well, and then we secure it down. The magnet is up here, so that when the child wears the processor, again, it sticks on with a magnet, and it vibrates this part. Again, there are no wound issues because the magnet sits completely under the skin. It's, again, a little bit larger, but not as big as the other one that I showed you, and the sound conduction is pretty good. So what about canal surgery, Atresia repair surgery? And this is kind of what I enjoy doing, and it's probably the most gratifying thing that I do. Now, I am going to show some surgical videos, so if you are a little squeamish, you can close eyes or just, look away. But in this surgical picture, you can see the stapes bone. This is the third bone, the little arch right here. This is the facial nerve. The facial nerve is the nerve that moves the muscles of the face. It lets us smile and close our eyes and raise our eyebrows. And then this is the first two ear bones that are fused together as one ear bone, the malleus and the incus. So who is a candidate for surgery? And that candidacy is based on several considerations related to age, related to the hearing test, related to the anatomy that I look at on the CT scan, and it's related to the maturation or how mature the child is. So in the office, after surgery, I have to remove packing, I have to clean the ear, and I have to be sure that the child can cooperate in the office so I can do all of the necessary cleaning and the necessary post-operative care. So that's an important consideration. And so the ideal age to operate, I think, is around 6 years old, 6 or 7, maybe just before the child is going to kindergarten or going to first grade. I think 3 or 4 years old is way too young. Children can't participate in the hearing test so that we know how well or how not well they are hearing. And then we don't know how the hearing is after surgery because they can't sit for the behavioral audiogram that we talked about earlier. Some surgeons advocate 12 or 13, and I think that's fine, but I would like the child to get hearing as good as possible, as young as possible. And that's why around 6 or 7, I think, is the ideal age. And so here's why I wait and not do it any earlier than 6 or 7. We have to do a CT scan. The CT scan delivers radiation. In a smaller child, there's a greater amount to the total body of radiation than in a 6 or 7-year-old. The eustachian tube is the bone and cartilage tube that connects the back of the nose into the middle ear. So every time we swallow, we yawn, we pop our ears, that's the eustachian tube opening to deliver air into the middle ear. In younger children, the eustachian tube is immature. And that's why children get lots of ear infections. They get fluid in their middle ear. I would hate for a child to go through this operation and their eustachian tube is not mature, and now they're getting ear infections and fluid in the middle ear. I mentioned accurate audiometry. We want to know how well is that child hearing before and after surgery, and a 3 or 4-year-old child really can't participate as well in a behavioral audiogram. And then I talked about cooperation in the office. My mentor, Bob Jarsdorfer, really kind of showed me the finer points of the canal surgery. And one of his great legacies is the Jarsdorfer score, or the Jarsdorfer scale, to evaluate the anatomy of the middle ear. So in this scale, each anatomic structure of the middle ear is assigned 1 point, and the stapes bone, which is that third ear bone, is given 2 points. So in a total of 10, 2, 3, 4, 5, 6, 7, 8, 9, 10, we give a score based on the anatomy of each of these structures. And so I generally operate on children with Jarsdorfer scores of 7 or higher. 6 or below, I just don't think the anatomy is developed enough to support good long-term hearing with surgery. And what we found in recent studies is that the middle ear space is really important. How big, what is the volume of the middle ear? In a very small middle ear, I think there is a higher risk of long-term loss of hearing because the ear bones become fixed or stuck again. In a nice big middle ear space, there's less room or there's less surrounding bone for the ear bones to become fixed. So I'll take you through a couple of images where children are not candidates for the canal surgery. So all this gray up here is the brain. Can you see how the brain hangs down here? This is the middle ear. This is the first two, these are the first 2 ear bones. I would have to take a drill and go through the brain in order to get to the middle ear in this image. And so this child, because the brain hangs too low, is not a candidate for canal surgery. This is the same problem. The brain is way down here. This is the inner ear, and there's no air. So air is black on a CT scan. Soft tissue, like the brain and skin and muscle and fluid, are all gray. There is no air in the middle ear, no air space, and there are no ossicles. Now in this scan, you see air in the ear canal here. Here are the ear bones on the left side. The atresia is on the right side. But if you can see this gray line right here, that's the child's facial nerve. That's the nerve that moves the muscles of the face. And so if we try to get an ear canal here, it blocks access to the stapes bone. That facial nerve would be at tremendous risk for injury if we were to try to open the ear canal on this child. And so just by virtue of the facial nerve position alone, I wouldn't recommend surgery for that on that scan. All right, so a couple things to know about the canal surgery. We do the canal surgery after rib graft. So if you've chosen the rib graft microtia repair for your child, we do the canal surgery after the rib graft. If you've chosen the MedPore or the Supor microtia repair, then the canal surgery goes before the MedPore. And the reason is the rib graft surgeon needs absolutely pristine, absolutely normal skin and subcutaneous tissue. If I were to put an ear canal there, the rib graft surgeon would have to face a lot of scar tissue for the rib graft. We do the surgery before MedPore because if we tried to do the surgery after MedPore, there would be a risk of exposing the MedPore implant. And if I were to expose the MedPore implant doing canal surgery, it wouldn't heal. And so you'd have to go back for another operation. I always monitor the facial nerve. So there are tiny electrodes that go in the skin and the muscles of the skin, so that if I'm dissecting near the facial nerve, the monitor will alert me and let me know to be careful around the facial nerve. And then we have to prep out the arm or the leg because I need a skin graft to line the new ear canal. So this is a child who's having surgery, canal surgery before MedPore. So you see the grade 3 microtia. This is the small incision we make behind the ear, and I incorporate the opening of the ear canal into the incision. I don't make a separate incision and then make the opening. The opening becomes part of the incision, and I'll show you that in just a little bit. So there are many different steps to the operation. The approach is an incision behind, drill the ear canal. I have to free the ear bones. So the ear bones have to vibrate freely in space. We take the skin graft. I have to place the eardrum down, and then I place the skin graft. So remember, there are 2 different grafts. there's an eardrum graft, and then there's a skin graft, and then create the opening. Okay, so here is a child with grade 2 microtia. So we start with the incision behind the ear, and the first thing I do is to harvest the eardrum graft. So not the skin graft, but the eardrum graft comes from tissue just above the ear. There's a big chewing muscle up here. If you clench your teeth and put your hand there, you can feel it clench. So there's about a coin-sized piece of temporalis fascia, and that fascia then becomes the eardrum. So now I have to expose the bone for the ear canal. I have to know and find the landmarks. Where do I start drilling? You know, if you think about it, I'm picking a place on the side of the skull, and I'm taking a drill and opening the ear canal. I have to know the landmarks of where to do the drilling. And the landmarks are the mastoid bone. It's this bone right here. You can feel a very prominent bone behind the ear. The glenoid fossa is the bone that separates the jaw joint from the ear. So if you put your finger right here in front of the ear and open and close your jaw, you can feel the glenoid fossa. The zygoma is the cheekbone. That's the bone right here. So you can feel your cheekbone that comes across the face, and then we raise this periosteal flap. So identifying these important bony structures gives me a roadmap of where to start the drilling and where to place the ear canal. So here I am, let's see, play this. Yep, so just taking a little instrument and pushing that soft tissue away from the bone to find those bony landmarks. The mastoid tip is down here. We'll find the glenoid fossa, or the temporomandibular joint, up here. You can see it start to dip down. And then the zygomatic root, or the zygoma, the cheekbone, is right in, above. So here you see a nice curvature right there where the jaw joint lives. So now we have our bony landmarks, and we take essentially a drill, and with irrigation and suction, so that the irrigation and the suction remove all of the bone dust, we start opening the ear canal. I stay very close to the jaw joint here, and very close to the zygoma right there. And what I want to do is find the bone that separates the brain from the ear. That bone has none of these air cells. It's just a solid sheet of bone. And once I find that bone, I follow it down into the middle ear. So here I'm using a smaller drill with a diamond burr. It polishes the bones, and it doesn't injure the bone. But this is the bone that separates. So this is a right ear, by the way. Sorry, I didn't orient you. The feet are down here. The top of the head is there. The nose is up at the top of the screen, and the back of the head is here. So you can see that the head is turned over to the side. This is a right ear. This is that bone. Oh no. Okay. So this is that bone that separates the brain from the ear. This is the bone that separates the jaw joint from the ear. So staying right up in this corner will take me to the middle ear. And that's what I want to find. So this is a left ear. Okay, so now we're kind of reversing orientation. Up here is the bone that separates the brain up here from the ear. So the feet are down there, the top of the head is here. So here we've made a little opening into this air pocket. Remember, the middle ear is an air space. It's an air pocket in the skull, and that's what I'm looking for. I'm looking for that air space. Once I've opened into the middle ear, then I find the ear bones, the first two ear bones, the malleus and the incus. They're together as one bone, and now the task is to remove all of this bone 360 degrees around those ear bones, so those ear bones can vibrate freely in space. Once I've removed all of that bone, we're back to a right ear now, I take a very sharp, very tiny knife, and I separate the attachments of the ear bones to the surrounding bone. So these are the ear bones right here. You can see them rocking just a little bit. And I'm taking this sharp blade and incising those attachments to the surrounding bone. And once I've taken those attachments down, we'll take a little bit of the bone away. And now you can see the ear bones are free completely around, or 360 degrees around. You can see down here the stapes bone, and so and then the first two ear bones here. So now we're ready for the eardrum. Before I put the eardrum on though, I take the skin graft. I take it either from the upper arm where there's no hair or the thigh. If the child's arm is a little bit on the small side, then I have a low threshold for taking the skin graft from the leg. But the leg works very well. It's very, very thin. It's 0.006 inches thick. It's about 5 centimeters or 2 inches. And then I prepare the skin graft. And the way I prepare the skin graft is this schematic here, this drawing. So it tapers because the outer opening of the ear canal is bigger or wider than the eardrum. So this is the eardrum side. And I create these tabs. And these tabs will line up over the eardrum graft so that the entire eardrum graft is covered by the skin graft. And I'll show that in just a second. All right, so we've taken that fascia, that connective tissue from behind the ear, and now we're going to place it down into the ear canal. This is going to be our eardrum. And so I carefully place it. Once it gets a little bit wet or hydrated, it's actually very easy to place. And I just drape it over those ear bones. And I want to tuck it around so that all of those ear bones are covered and the graft comes up. Oh. Okay. So again, the fascia graft, as it hydrates or as it gets wetter, it really drapes nicely around those ear bones. And many times you can actually see the ear bones through the fascia graft. And so the ear bones, I want them to kind of stick out from the fascia graft as the fascia graft is placed 360 degrees around the canal, and it drapes up onto the canal by maybe 1 or 2 millimeters. So you can see the ear bones are through there, and then the eardrum graft comes up onto the ear canal. So next is the skin graft, and that's hard. It just takes time and it takes careful attention to detail. But those 5 tabs line up over the eardrum graft, and then the skin graft comes up and layers or is placed all along the bony ear canal. And so I won't play this whole video because it's a little long, but you can see the tabs that are coming into the canal. Here's the eardrum graft. And so now I'm taking just a small blunt instrument and unrolling those tabs. And as I unroll them, they sit down on the eardrum graft. And so I do that all the way around. Just kind of go around like a clock to place those tabs over the eardrum graft. So the entire eardrum graft is covered by the skin graft. So 2 grafts, the eardrum graft and the skin graft. And the skin graft just lines the entire bony ear canal. I think you can get an appreciation of how tedious this is. It takes time and practice. Once the skin graft is placed, I have to secure it in place. And so I use a piece of silastic and some wicks, some little sponges, to secure the skin graft in place. And so this little video illustrates or shows, this is the silastic disc. that goes down over the skin graft and the eardrum graft. It holds everything in place. Once that's placed in, I'll take about 3, 4, or 5 of these little sponges that stand up in the ear canal, and once they're placed, I'll use an antibiotic ear drop to expand the sponges so that the sponges hold the skin graft against the bone, and that's where the skin graft gets its blood supply. Oh no. Sorry. I don't know why that's happening.
你看这地方能给它那个线卡住
Videos or
不是线，
这是屏保，
屏保啊。
啊，
it only
屏保把它关了就行。
let's fast forward that. Okay. There's just one more video after this one, and that's it. So I just want to show you how when you wet these with the antibiotic solution, they expand and they hold that skin graft and the eardrum graft down. And then I fold over the outer part of the skin graft, getting ready to make the opening. So here's the opening. I create a little flap up here, and that gets delivered down through the new ear canal. And then I deliver the skin graft out. So now it's a right ear again. You're looking through the ear canal, and there's the skin graft. And the edges of those skin graft are brought out. Here's the wicks, or these are the sponges. And then I trim a little bit of the excess or extra skin graft. And then I'll sew the skin graft to the child's skin at the opening. So you can see the wicks, the sponges right there. And then we're just taking some absorbable suture and suturing or sewing the skin graft to the native skin. Once that's done, we put more wicks in, more sponges in, and we'll put the antibiotic solution on those sponges. Again, they'll expand and hold everything in place. If the child has, or if the family has elected to do MedPour, then everything is right here. And you can see the incision I was mentioning earlier. Here's a little bit of the incision that's closed, but most of the incision is incorporated into the opening or into the meatus. And so we've got the sponges in the opening, and that looks good, and now the child will be ready for the MedPour in about 6 months. I recommend waiting a minimum of 3 months, but probably 5 or 6 months before doing MedPour after the canal surgery. All right, so what are the hearing results? This graph shows a study that we published probably 10 years ago, looking at 106 ears. The Jarsdorfer scale is here on the x-axis, 6s, 7s, and 8s. And on the y-axis is the percent of ears with postoperative speech reception threshold of less than 30. So the higher you go, the metric is very good hearing. And so the higher you go is the greater percentage of children getting very good hearing. So it clearly shows if they're 6 or below, there's only about a 45% chance that we can get good hearing with the canal surgery. But for children 7, 8, or higher, there's an 80 to 90% chance of getting very good hearing after surgery. Now, this study was done at the first postoperative hearing test, which we do about 6 weeks after surgery. How about long-term? About 4 or 5 years ago, we published our long-term hearing results, because I noticed that over time, some children had some decline in their hearing. They had really, really good hearing right after surgery, but some children's hearing declined. And so this is kind of all of the subjects in the study. You can see, so the higher you go, the worse the hearing. The lower you go on the y-axis, the better the hearing. So you can see before surgery, children had 40 to 80, then it came down, and then some actually got better over time, some stayed the same over time, and definitely some got worse over time. So the take-home message was that the average loss was about 8 decibels over the long term, and the average long term was 4.5 years. So we still didn't do, the life of the child, of course, but for 4.5 years, that's a pretty good amount of time after surgery to understand or know if the child is going to have stable hearing, if the child is going to have improved hearing, or if the child's going to have a little bit worse hearing. We looked at complications of surgery. There are complications including ear canal stenosis. We make a nice, beautiful, open ear canal, and over time it just closes shut. That was the most common complication, and in the next slide I'll show you how I deal with that. There's chronic drainage or infection. Sometimes over time, the skin graft, I think, sloughs off, or it dies, and it's replaced by mucous membrane. Mucous membrane is the tissue inside the nose and inside the middle ear, and mucous membrane makes mucus. So some children have kind of a moist ear. And then isolated conductive hearing loss in about 20%, meaning they have a good ear canal, but the hearing declined over, it was good right after surgery, but it declined over time. Now in that situation, we can go back in and repair or liberate, or it's usually because the ear bones have become stuck. We can free them again, or a child can wear a conventional hearing aid in their new ear canal. Avoiding stenosis. So there are 2 things that I do when I start seeing the ear canal start to stenose or narrow. One is we can inject the skin around the ear with a steroid, and steroids reduce scarring. They reduce inflammation or the inflammatory reaction that causes scar tissue formation. And then I'll have parents put a foam earplug at night that's coated in a water-soluble lubricant, and in the morning, take it out so the child can have the good hearing during the day. But that might be several months of using the foam earplug at night to prevent narrowing of the canal. So I'll conclude with some thoughts comparing the ear canal surgery with BAHA, or the bone-anchored hearing aid, because there are pluses and minuses to both procedures. With the canal surgery, it's difficult, it's challenging surgery. It's technically difficult. There are some complications. There are variable hearing outcomes. Some children get amazing hearing after surgery, and some get modest hearing. Our long-term study did show that of all the patients, their hearing was better, even in the long term, compared to the pre-op hearing. In other words, even if they lost a little bit of hearing over time, that final hearing result was better than when they started, before surgery. Can they locate sound in space? There are a couple of studies in the literature that do show that children after canal surgery are able to locate sound in space, and they're able to hear better in background noise. And then some just like to have the opening, the hole in the ear. With BAHA, on the other hand, the surgery is easy. You make a skin flap, you open the skin, you put the implant in, and you close it. There are minor complications. The hearing results are excellent. I can't deny how good the BAHAs are. The BAHAs are predictable. We know how good your child is going to hear after the BAHA because of the studies and because of the sound conduction, the efficiency of sound conduction through bone. Cosmesis, that you do have to wear a processor behind the ear. Can they locate sound, and is there improved hearing in noise? The answers to that, I think, pretty clearly are no. They really still can't locate sound in space with a BAHA, and in noise, a lot of children take them off, and the scientific studies show that there's no improvement in hearing in noise with the BAHA. So we'll just look at 2 studies that compared. This study compared 20 patients who had canal surgery with 20 patients who had a BAHA. The hearing gain was 47 decibels at 6 months and 40 decibels at 12 months. And what this study showed, that the aided canal surgery results were comparable to BAHA. Even though BAHA had better hearing, predictably, less variability, if you added a hearing aid to the new ear canal, those hearing results were comparable. And the second study looked at 516 patients who had canal surgery and 100 patients who had BAHA. 60% of the canal patients had a pure tone average of less than 30 dB. That's really good hearing. Whereas 96% of the BAHA patients had that good hearing. An air-bone gap, ABG, is the difference between their bone conduction and their air conduction. An air-bone gap of less than 30 dB is excellent hearing. About 70%, 69% in the canal, 98% in the BAHA group. The hearing gain, why that? Yeah, the hearing gain, that means how many decibels of improvement did the child get? 24 decibels in the canalplasty and 38, so more improvement in the BAHA. You know, I love the operation. I think the operation is amazing, but I can't argue with the data. I can't argue with the predictability and the less variability of BAHA. I think the downside of BAHA, again, is sound localization and hearing and background noise. There are studies in the literature that show improved sound localization. We've done study, but we haven't published it yet, but children do hear better, or they do locate sound better in space after canal surgery. Still not as well as two normal hearing ears, but definitely better than before surgery. All right, so to finish up, options for hearing improvement. Number one, preferential seating in class. Alerting the school and alerting the teacher that the child has a hearing loss, making sure they sit near the front of the class. An individualized education program. Perhaps the school or the state has a program where children can be enrolled in the US it's called a 504C plan, but an individualized education program. An FM system, again, the teacher wears a microphone and the student or the child wears an earbud or a receiver and speaker in the good ear to improve the ability of the child to hear the teacher's voice. A conventional hearing aid, if there's some development of the auricle and some development of the canal. We talked a lot about bone conducting technology and BAHA, and then of course the canal surgery. So those are really the options to set your child up for success in the classroom. So know all the options for hearing improvement with children with CAA, with oral atresia in one ear and in both ears. Again, as I mentioned, I feel that bone conducting technology is a must in children with oral atresia in both ears, but the benefits of bone conducting technology in children with oral atresia in one ear are really still unclear. Surgery for oral atresia is difficult. The patient selection is very important. It's about audiometry and it's about the CT scan anatomy. And so, with that, I thank you, and again, thank you to Mr. Jin. Oh, where's the picture? There it is. That's the two of us at the Great Wall. And I thank you for coming today, and thank you for your attention.